What is the mechanism of trauma? Fall from ladder. बताओ, what is the mechanism of trauma? बताओ, सामने लिखा हुआ है, पूरा सिनेरियो है. Fall from ladder. He fell down. He had a blow to the right flank. 1 hour back. ठीक है. So this is
blunt trauma.
Blunt trauma. ठीक है. आप बताएं what other classifications of trauma? बहुत पढ़ना है. तेजी से इसी तेज से निकालना. अदर अभी इसने कहा blunt trauma. Blunt trauma में एक ये आ गया. और क्या हो सकता है blunt trauma में? Penetrating injury. और penetrating में क्या आ जाता है? जल्दी बताओ.
Stab wound.
एक stab wound और gunshots. Gunshots दो टाइप के होते हैं. Low velocity, छोटे मोटे. ठीक है ना. हम तो इस इलाके के ना जब बंदूकें चलती हैं. ठीक है ना. स्लो छोटी वेलोसिटी पिस्टल हो गए. हाई वेलोसिटी स्प्लैश एंड कॉफ. ठीक है. और भी नाम ले. अच्छा, और अब ब्लंट ट्रॉमा में एक चीज मिस कर रहे हो. वो क्या है? वेरी इंपॉर्टेंट रीनल इंजरीज. फॉल फ्रॉम हाइट डाउन टू द लैडर. डिसेलरेटिंग इंजरी. ठीक है. ये सो हिस्ट्री इज ऑलवेज वंस यू डन द ATLS, नाउ यू गो फॉर डिटेल हिस्ट्री कि ये हुआ कैसे था. इट विल हेल्प यू इन डिसीजन मेकिंग फर्दर ऑन. ठीक है. चलिए, लेट्स गो विद द स्लाइड्स and see what we have said.
So the epidemiologies of the road traffic accidents are major causes of long-term morbidity and mortality in developing countries. Genitourinary injuries accounts for 10% of all abdominal trauma. Renal trauma accounts for 5% of, and genitourinary accounts for 84% of all abdominal traumas. Early diagnosis is important for to prevent serious complications. So as we discussed, the renal trauma can be classified into blunt and penetrating injury. 80 to 90% blunt traumas have a direct blow to the kidney, such as in our scenario, fall from the ladder, direct fall onto the flank. And there is a rapid acceleration and de-acceleration injury causing avulsion of the renal pelvis and renal vessels, such as in RTA or fall from height. These can be combined in same case also. Then there's penetrating injury, which is 10 to 20%. Most common are gunshot injuries, and the second one are the stab injuries. Penetrating injury is more severe and less predictable. Bullets are mostly associated with with multiple organ injuries, which are almost 77% in cases. Direct disruption, it causes direct disruption of the parenchyma, vascular pedicels, and collecting system. Penetrating trauma, the site of the penetrating trauma is important. Interior axillary line disrupts the renal pedicel and hilum, so it's more damaging. And penetrating trauma posterior to the anterior axillary line damages renal parenchyma. So the patient presents mostly with microscopic or gross hematuria. There is tenderness or ecchymosis over the flank and the upper quadrant of the abdomen. Diffuse abdominal tenderness on palpation, and there can be a distended abdomen with absent bowel sounds.
Okay. Now here is microscopic hematuria or gross hematuria. Tell me the relevance of hematuria with trauma. If the patient does not have hematuria, will it mean that he is safe? If he has gross hematuria, does it mean that he has severe injury? If he has microscopic injury, microscopic hematuria, does it mean that he has some injury in between? Any comments on hematuria?
Well, the absence of hematuria does not rule out the genitourinary trauma. So we should always be cautious and keep the patient under monitoring. And yes, the presence of hematuria is suggestive of trauma that starts from the kidney down to the ureters, bladders, and urethra.
Okay.
And the presence of gross hematuria is always always alarming, and it guides us to in further management. Like we have to put in the catheter, 3-way wide bore, start irrigation.
Now, in this scenario, suppose if this patient had a significant decelerating injury, and he has microscopic hematuria. Would you be concerned about the patient, or would you remain relaxed?
We should be concerned about the patient when he has microscopic hematuria.
Why?
Because deceleration injuries can cause injuries at multiple levels in the urethra, especially injuries to the bladder neck. Or,
Only renal trauma. We're talking about renal trauma. Bladder ko to chhod dein.
yes, the deceleration injuries mostly cause hyperextension of the spine, and which can disrupt the renal pedicle and the intimal tear to the renal artery.
Okay. One. Number two. और क्या करते हैं?
It can cause PUJ avulsion.
PUJ avulsion. So PUJ avulsion, that means that the pelvis, that the ureter has been avulsed from the pelvis. There is no output, and then there is, so microscopic hematuria would mean that the pelvis has been avulsed. It requires, there's leaking, urine leaking, but there is no significant feature of hematuria. And the second thing of that stretching of the renal hilum, if the hilum is stretched, there's intimal tears within the renal artery. So renal artery, there's tears within the mucosa. There is exposure of the submucosal fat, thromboxanes, platelets, and then there is thrombosis of the renal artery, leading to devascularization of the kidney. Ischemia of the kidney. ठीक है हो गया? Good. So if you have gross hematuria with hypotension or microscopic hematuria with hypotension, it is always a matter of concern. The mode of injury, the vitals of the patient, and your clinical examination will determine how severe the injury is going to be. That is why that is why a detailed history, जब हम जाते हैं ना पीरियड्स में बशीर साहब पूछते हैं बताओ ट्रॉमा कैसे हुआ है. I hope you understand now कि वो क्यों इतने बार-बार हम कहते हैं यार क्या बार-बार नहीं दोबारा जाओ पूछ के आओ. This is why, because they are going to decide what is going to be the future plan of this patient regarding the trauma. That's why history, the ATLS protocol, and your physical examination is very important. ठीक है? चलें आगे चलते जाते हैं तेज.
So the evaluation starts with the assessment of hemodynamic stability, record the past renal surgery or any pre-existing renal abnormalities such as PUJ or solitary kidney in the stone presentation, and we should evaluate the hematuria as we discussed. One of the signs of retroperitoneal hematoma is gray Turner sign, and this can present as a palpable mass when there is large retroperitoneal hematoma or urinary extravasation. But if retroperitoneum has been torn, free blood may be noted in the peritoneal cavity and there is no palpable mass. This is the picture of the gray Turner sign bilateral. So now comes the imaging.
Anyone from Sakkar? I've been told that someone wanted to comment from Sakkar. कोई Sakkar में है? Okay, we'll continue then. Okay, so now you've assessed this patient. Tell me how will you proceed on imaging? अब किससे पूछें? हाँ. So how will you now proceed to investigating this patient?
So first of all, we'll go for the ultrasounds.
Okay.
So ultrasound, we can get to have retroperitoneal collection or anything or any bleeding. Then we'll proceed to CT. In CT, we can have a proper imaging regarding the other traumas, any related abnormality or any bleeding or any hematoma.
ठीक है. सही है. तो पर any basic देखिए पहले तो आप यूरिन डीआर माइक्रोस्कोपी तो करेंगे हेमाचूरिया की बेसलाइन. ठीक है हो गया. Ultrasound is very non-specific, but it's a screening test. जैसे हम करते हैं it's a screening test. It can show you collections, extravasations, ठीक है, contralateral kidney. But all this is available when the patient is stable. In our scenario, the patient right now is stable, so we have investigations at our disposal. Now, when she says CT scan, so CT scan तो बहुत ज़्यादा है ना. It's CT scan abdomen, CT scan KUB, but there is a particular CT scan in trauma. तो वो CT scan कौन सा होता है?
CT contrast we'll be doing because we want to see the collections or any extravasation in that might show. Okay,
so anyone from the senior who can explain the different phases of the CT that we do, और उस phases में हम क्या देखना चाहते हैं?
So regarding genitourinary trauma, we go for CT urogram or CT chest abdomen pelvis with contrast with delayed images, preferably. For this, in arterial phase, we look for any arterial leaks or any arterial phase. And then in the portovenous phase, we look for any damage of the renal parenchyma. And in delayed images, we look for the injuries to the pelvic ileal system and the ureter.
ठीक है. So if we talk about how the CT works in renal trauma, then the first phase is the nephrogenic phase. Nephrogenic phase is where the contrast is going into the renal artery and illuminating the cortex. What do we want to see in the nephrogenic phase?
The arterial phase, you mean?
Arterial phase. So what we see is we want to see the vascularity of the kidney. If there's renal artery thrombosis, वो नजर आ जाएगा. If there is any leak from the artery, there will be extravasation of the contrast. If the parenchyma is not illuminating, that means there is something wrong with the renal artery. Then the second phase is the delayed phase, which occurs about within which the time that is given is by majority is within 10 minutes, but researchers have seen that the optimal time is 9 minutes. So what do we see in the excretory phase?
In excretory phase, the contrast is seen going from the cortex into the pelvic ileal system. So we look for the injuries to the calyces, the renal pelvis, the proximal, middle, or distal ureter.
And then, ठीक. Over here is the indications of imaging. ठीक है? These are very important, and you will probably by reading these 5 indications, you will understand that most of the patients, at least 90% of the patients who come with renal trauma, will receive this protocol of CT scan. चलें, आगे चलते हैं.
So the indications for imaging are visible hematuria, non-visible hematuria with one episode of hypotension, that is systolic blood pressure less than 90 millimeters of mercury, history of rapid de-acceleration injury or associated injuries to the abdomen, penetrating trauma with clinical signs suggesting renal trauma such as flank pain, abrasion, fractured ribs, abdominal distension or mass or tenderness in the abdomen. All pediatric patients with shock and microhematuria.
Okay, hold it. All pediatric patients. बाकी सब में all नहीं कहा है, but pediatric patients में all क्यों कहा है? Why? All pediatric patients. यहाँ से पूछते हैं जो pediatrics किए हुए. Why pediatric?
It's all pediatric patients with shock and microhematuria.
जी सर, जी सर, जी सर. बस ये मैं सिर्फ पीड्स का जरा पेशेंट्स को जरा emphasize करना चाह रहा हूँ कि why pediatric patients are more prone to imaging. उनकी 3 चीजें होती हैं सर, वो मैं इनसे रेजिडेंट से पूछना. आपके पास रेजिडेंट्स हैं सर, तो उधर भी आप पूछ सकते हैं.
बहुत सारे. आंसर करना चाहिए.
Anyone बताएं?
Dr. Bilal wants to answer. Yes,
Please, sir. Please, sir.
किडनी बच्चों में सर हालत होती है थोड़ी सी.
हाँ बताओ कौन सा.
और ऊपर से मस्कुलरिटी की भी कमी होती है, उस वजह से भी क्या कहते हैं, मतलब इजीली रीनल इंजरी हो सकती है.
ठीक है. और अच्छा, anyone else? 3 चीजें बताऊंगा कि which makes imaging in pediatrics more important. हाँ.
एब्डोमिनल का सरफेस एरिया कम होता है और पैरारीनल फैट जो है वो बच्चों में कम होता है, जिसकी वजह से इनकी किडनी ज्यादा प्रोन होते हैं टू इंजरीज.
Yes, so the renal volume, body surface area is more as compared to the adults. ठीक है. और something is very special in the children is that when they are bleeding, these children have more release of catecholamines as compared to the others. So they are able to maintain their blood pressures in shock for a more prolonged time as compared to the adults. Once the bleeding goes to across a certain level, when it comes massively, these children immediately dip and go into irreversible shock. So that's why it is mandatory that you, for pediatric patients, the imaging and the resuscitation process goes hand in hand. And one more thing, pediatric patients के अंदर congenital anomalies होती हैं? What type of, so if they have congenital anomalies, for example, like, बताएं, पूछें, pelvic ureteral junction obstructions, renal stones, so these kidneys are prone to trauma, or they require a lot of significant magnitude of trauma. बताएं. So any kidney which has congenital deformities like a PUJ or renal or some renal stone or some anomalies, they can give you a history of a very subtle type of trauma. For example, riding a bicycle, the handle hits to the abdomen. It's a very subtle trauma, but the result that you see on imaging can be more as compared to the history. Okay, next, let's continue.
These are the imaging options. We routinely do ultrasound at presentation. This fast ultrasound. Then the multi-phase CT scan is done. Diagnostic accuracy of MRI is similar, but due to logistic issue, which is not practiced routinely, IVP can be performed if CT is not available. And CT 3-phase with urography is a choice for ureteric injuries.
Okay, now let's hold it. Now we are all from different parts of Pakistan. We are right now in a level 1 center where we have all these modalities at our disposal. Now we are discussing this scenario. The patient is stable, so we have all this in our leisure. But in different parts of Pakistan, where if you are working in a level 3 area like a THQ or some other hospital where you don't have a CT scan, what other options you can have? What other ways you have to image the kidney on the table? Are there other options there? One, we have given you that the one-shot IVP. If anyone can start with the one-shot IVP. So what is the one-shot IVP?
In the setting of renal trauma, when the patient is on table and you are going to look for the renal injury, there is this concept of one-shot IVP to document the function of the contralateral kidney, mainly, in which 2 ml per kg contrast not exceeding more than 150 ml is given to the patient on table, and delayed after 5 to 10 minutes in intravenous one-shot IVP is taken to look for the contrast uptake in the contralateral kidney. But it is poor to, but it does not give us an account to the ureteral injury.
Okay, just to clarify, the one-shot IVP is done on table, milligrams per kg is given, and then the radiograph picture is taken within 2 minutes. You're right to see the function of the presence of the contralateral kidney, but it is an unreliable test at times. For example, if the patient is hypotensive, the kidneys might not be excreting, so you get a poor result. Okay, one is the IVP. Anything else? Anything else? किसी को पता है तो बताएं, ना मैं आगे चलूं. There's a lot to discuss. Okay, one option is that you don't have the facility of a radiograph. So one thing that is reported that you take the ureter, the ipsilateral or injured ureter on the sling, you clamp it, put in an IV methylene blue, and you see the Foley's bag. If you see that the methylene blue is coming in the Foley's bag, that means the other kidney is normal. But what trauma surgeons usually do is they go to the opposite side, palpate the kidney. If the kidney is there, then they move ahead. These are options in peripheries, not in grade 1 trauma centers. Okay, let's continue.
So we discussed the three phase of multi-phase CT scan. Arterial phase, which is taken at 80 seconds, shows vascular injury or presence of active extravasation of contrast from the renal artery. And there is a nephrogenic phase, which shows a parenchymal contusion or laceration. And the delayed phase, which should be done by 10 minutes, identify the collecting system or ureteric injury. So the CT scan finding, which raise a suspicion of major renal injury or medial hematoma, suggesting vascular injury. medial urinary extravasation, which is suggested of renal pelvis and PUGA avulsion. There's a global lack of contrast enhancement on parenchyma, such as in renal artery occlusion. And on axial CT, the hematoma rim distance more than 4 centimeter, or there is medial laceration or vascular contrast extravasation, such as in grade 4 renal injury. Now we'll discuss the American Association.
Now we stop. Now you've done the CT scan in that scenario. That CT scan, remember, it will be you and the radiologist will be sitting together and bringing out the findings. Now the classification of renal trauma, very important. Who can narrate it quickly?
So, sir, and the classification for the renal trauma is from 1 to 5. So, in grade 1 injury, there is contusion of the renal parenchyma, and the grade 2, there is less than 1 centimeter laceration, and there is no extravasation of urine from the pelvic calyceal system. And grade 2 injury, there is more than 2 centimeter laceration, and there is no extravasation as well. And more than 1 centimeter. And in grade 3, okay, and in grade 4, there is laceration that is extending up to pelvic calyceal system, and there is contrast extravasation from the pelvic calyceal system. And in grade 5, there is shattered kidney, and there is a renal hilum injury.
Anyone on it?
Grade 4, there is a vascular injury with contained hematoma. Arterial thrombus.
Anyone else? कोई है तो बताएं वरना
बोलो नहीं तो बता रहे भाई कौन है
सर ग्रेड 1 के अंदर जो है कंफ्यूजन होती है रीनल, उसके अलावा फिर ग्रेड 2 आते हैं, उसमें लेस देन 1 सेंटीमीटर की लेसरेशन हो सकती है, कोई एक्सट्राविजेशन नहीं होती। ग्रेड 3 में मोर देन 1 सेंटीमीटर का क्या कहते हैं लेसरेशन है, और उसके अंदर भी एक्सट्राविजेशन नहीं होती। ग्रेड सब कैप्सुलर हेमाटोमा हो सकता है उसमें। और ग्रेड 4 में क्या कहते हैं एक्सट्राविजेशन ऑफ यूरिन भी हो सकता है, सब कैप्सुलर हेमाटोमा भी हो सकता है। और ग्रेड 5 के अंदर क्या कहते हैं आपकी किडनी जो है वो शटर्ड होती है, हाइलम भी इंजरी हो सकती है, और रीनल वेसल्स को भी इंजरी होती है।
अच्छा देखें, what we've assessed is that सब कच्चे हैं, ठीक है, in renal trauma. You need to understand the grading because it's a very common trauma. You need to understand the trauma system. When we grade renal trauma, जैसे मैंने याद रखने के लिए दो चीजें, the kidney system is made up of two things. One is the parenchyma, one is the vascular system. So when you start classifying or staging trauma, then remember there is one aspect is the kidney parenchyma, the kidney calyceal system, and then after grade 3 onwards, you have damage to the vascular system, that is the renal artery, renal vein, and the arterioles that are supplying into the calyceal system, the arterioles, arcuate arteries. So you have to understand the classification of this trauma as dividing into parenchyma and renal artery, renal vasculature. Now the one that you were telling is the 1980s edition of the ASST, American Trauma Association grade staging scale. But in 2018, they've just revised it, extending on the vascular injury aspect of the kidneys, and they've added the AIS severity scoring. Now the AIS is basically known as the abbreviated injury scale. 0 is mild, 6 is unrepairable or untreatable. It's out of the context of this lecture at this time, but this grading system is something that you should all remember and apply with the radiologist when you see a patient of renal trauma. So we've now graded this patient in the scenario. Let's continue ahead.
So these are the pictorial presentation of the grades of renal trauma. This is the grade 1, which is shows there's a subcapsular hematoma, and there's a contusion represented by B. Then in grade 2 injury, there is a perirenal hematoma, which is confined within the Gerota's fascia, and there's a laceration which is less than 1 centimeter, and there's no involvement of the collecting system. In the grade 3, there is again a laceration which is more than 1 centimeter, but the collecting system is not involved. There's no extravasation of any contrast. The B represent the active bleeding and causing hematoma in the Gerota's fascia. And additional is this, there's a renal vascular injury, which is beyond the segmental branches, and there can be pseudoaneurysm or AVF formation. This is the grade 4 renal injury with laceration more than 1 centimeter involving the collecting system, causing urinary extravasation. Then there's B shows that there's disruption at the PUJ causing extravasation. Then the C is the segmental pseudoaneurysm or AVF formation. D is the active bleeding which is causing and hematoma which is beyond Gerota's fascia, and it is in retroperitoneum or can be in peritoneum also. Then there's a segmental arterial thrombosis which is causing segmental ischemia of the upper pole or the segmental area. This is the grade 5 shattered kidney with multiple laceration causing active bleeding and trauma in the retroperitoneum. And the grade 5 vascular injury, which is at the level of renal artery avulsion, and there's a hematoma formation there, causing devascularized injury to the kidney. These are the CT images showing the different grades of renal trauma. The first one shows the grade 1 renal trauma with focal areas of decreased contrast and contrast enhancement in the cortex of the right kidney. On the left is again subcapsular hematoma, but there is no laceration. This is also grade 1 renal injury. The grade 2 renal injury, there is small cortical laceration and small perinephric hematoma, which is presented by arrowhead. This is the grade 3 renal injury with laceration exceeding more than 1 centimeter and without involving of the collecting system. There is no contrast extravasation. And in this CD, there is a large subcapsular hematoma and renal laceration involving cortex and medulla, but collecting system is spared. This is the grade 4 renal injury. We can see there is a extravasation of contrast at the lower pole. This is the CT of a shattered kidney on the left side, and there's a devascularized injury causing devascularized injury on the left side.
Okay, now in our scenario, this patient has on the CT grade 4 injury, but blood pressure is, vitals are stable, hemoglobin is not dropping, hematuria is present, and CT shows grade 4 injury. So how will you manage this patient now? Or before management, let me ask, the attendants come to you of this patient, and you tell them about the injury, and you tell them how grade 4 is described to the attendants. Now they're worried. So you need to explain them why you're going to observe this patient for now. And they are worried that such a high injury and we're going to observe, not do any surgery. So do we have any normograms? Do we have any assessment tool in which we can predict the risk of bleeding? This question is to those who are going to appear in the exam. This question is for those who are going to appear in the exam.
मैनेजमेंट में सर क्या कहते हैं, हेमोडायनामिकली स्टेबिलिटी देखी जाती है. अभी जैसे कि पेशेंट एक तरीके से हेमोडायनामिकली स्टेबल है, तो उस लिहाज से फिर देखा जाए तो यूजली मैनेजमेंट जो है कंजर्वेटिव रहती है. अगर हीमोडायनेमिकली अनस्टेबल होगा तो फिर तो एक इमरजेंसी होती है, फिर उसके अंदर क्या कहते हैं लोग इमरजेंसी लेप्रोटमी के साइड जा सकते थे और फिर एसेस करते. मगर चूंकि हीमोडायनेमिकली स्टेबल है तो इसलिए
वो बात तो ठीक है, but I've given you a scenario in which the patient is hemodynamically stable. But the question is, we are going to explain to the attendants on this patient, because on one side we are saying that he has severe renal injury, but on the other side we are saying we are going to observe this patient for now. So we need to provide them with certain robust data to the attendant to satisfy them that yes, this is why we can observe this patient because of certain normograms or calculators that we have that can predict the risk of bleeding in this patient. चलें और बड़ा clue दे दिया. This question again is for those who are appearing in the exam. बस सही, give up हो गई. चलें.
So newly nomogram has been.
जी. And FCPS Part 2 exam and the MS.
There are actually 3 risk factors that conclude for
not appearing for the exam actually. तो वो उन लोगों को चांस हो ना जो वो दरअसल IM का इम्तिहान दे रहे हैं, वो shying away from actual question. You are not appearing for the exam. जो appear कर रहे हैं exam के लिए वो खामोश बैठे हुए हैं.
ठीक है.
शेरशाह आप बताइए, आप क्यों खामोश बैठे हुए हैं? Why you are shying away कि मैं इम्तिहान देने वाला हूँ? हॉल में बहुत सारे लोग बैठे हुए हैं लेकिन बोल कोई नहीं रहा. सामने कोई, या तो वो छुप गए कुर्सियों के नीचे.
कुछ भी.
Sir, I haven't read the studies which can share to show the exact percentage.
सब मैं कंटिन्यू करता हूँ.
बिल्कुल, इसलिए कि आज शाम को इसी का MCQ है. इत्तेफाक से 4 बजे आप ये MCQ कर रहे होंगे और उस वक्त आपका स्कोर बहुत अच्छा आ रहा होगा. तो याद रखिएगा, मुझे तो कुछ भूलता नहीं है, आप लोग बड़ी जल्दी भूल जाते हैं.
अच्छा, देखिए, why all of this is now important is because litigation is something that is now coming into our country as well. You need to have data to back your decisions. So there was a nomogram which was presented by the multi-institutional genitourinary trauma MUGIT, जिसका नाम बड़ा famous है, and they presented a doctor there named by something SK. He presented a nomogram that can detect the risk of bleeding in renal trauma, and it's a scoring system consisting of 5 components, and you can calculate the risk of bleeding and you can move ahead from there. We'll show you how to calculate, but again, this is to be done with the urologist and the radiologist sitting together.
So it is a nomogram which has 6 components, including trauma mechanism, hypotension and shock, concomitant injuries, vascular contrast extravasation, pararenal hematoma, and hematoma rim distance. So it starts with the measuring the hematoma rim distance on the CT scan, and such as in this case, there is 3 centimeter hematoma, and we can calculate from this scale that at 3 centimeter the score is almost 25, and the rest of the parameters are added in this. In this scenario, there's no shock, so there's 0 for this point, and there's isolated renal grade injury. There's no concomitant injury, so there's 0 point for this also. There's a penetrating injury, so the score is 34 for this, and there's no perirenal hematoma. It is confined to not extending to pararenal, so there's 0 point for this parameter also. Without active contrast extravasation, again, there's no contrast extravasation in this scenario, so again 0 point for this. At the end, with sum of all these scores, we get it's a total point of 59. So according to this nanogram, and 59 is almost, there is 10% in probability of intervention in this case.
So then you can explain that as per this, there's 10% chance we are going to observe something that can satisfy. But another normogram, if the example is on the contrary.
So this is another example. In this, there is this hematoma rim distance is more than 9 centimeter, and so for 9 centimeter the points are 75, and for other parameters we have to add again that there's shock. Patient presented with shock, those 16 points are added, and there is blunt trauma. There is no penetrating injury, so for this there is no point. And upon there's the CT scan, there is liver and splenic laceration, so concomitant injuries are present. 16.5 points are added to the total. Then there is a multiple deep laceration of the kidney. There is a contrast extravasation, so 29 points are added. Again, there is extending, the hematoma is extending into the pelvis. There is pararenal extension, so the 20 points are added. The total points for in this scenario is 156. So the probability of early intervention is 90%, and this shows the importance of this nanogram.
Dr. Mazahir, what is the name of this nanogram?
Sir, it's called the Muget nanogram, and it has been.
It's not nanogram, it's
nomogram.
Normogram, sorry, sir. Normogram. So it's basically a group of people, Kehani S, who worked on it, and it has been published and it has been validated as well.
Yeah, but I guess this is not present in the guidelines at the moment, or is it?
Sir,
because I am not sure about the 2025 guidelines.
European meaning American.
Aसल
में where this topic is coming from, they have combined the European and the American guidelines.
It is present in Campbell 2020.
It has been published in Campbell 25.
Campbell 25?
Yes,
25.
Okay, but the bottom line is you can put these nomograms and everything, but not at the risk that you start calculating it and the patient is deteriorating over there. So if the patient is deteriorating, keep the nomogram aside.
Actually, it's nanogram because it is at the far end of your memory. Then it becomes nanogram, 10 to the power minus 9 millimeters centimeter.
So the bottom line is don't wait for filling those forms. Shift the patient to the OR if the patient is deteriorating. This is what I mean to say.
Okay, so now this patient you've seen counseled the attendants. You've shifted the patient to SIUT and you've planned conservative management. So now tell me, patient is there in the ward. You come in the morning and he's grade 4 renal trauma. Everything is there. How will you follow this patient, or how will you evaluate this conservatively managed patient? Kaise karte hain? What investigations would you do? What clinical examination you would do? At what frequency? At what time?
So, before proceeding for the assessment, we must know the mechanism of injury, how the patient sustained the trauma, and we will thoroughly examine the patient and apply ABCD of the primary survey, and after concluding that there is no other injuries, and confirming that the patient has sustained renal trauma, then
You need to make sure that the patient is vitally stable. What frequency? 4 hours. TBC का repeat करेंगे. 6 hours to see if there is any clot. ठीक है? And physical examination.
These patients are kept in HD or ICU with a monitor attached, and we keep an eye on their vitals as well as the Foley output.
The hematuria.
And hematuria. And we go for the serial HB monitoring every 6 hourly, as we already said. Or
I would like to now emphasize on what Dr. Harris said, physical examination. you have to examine this patient. Even though everything is, you have to examine this patient because certain things can come up which can make you move ahead in the management of the patient. Okay. Now let's go. Now let's put a twist in this scenario. Quickly, but 5 minutes. Now you've examined flank pain has increased. Patient is now developed gross hematuria. HP has dropped. So what will you do now? क्या करेंगे बताओ हंगामा मच गया कुछ हो गया
सर वाइटल्स देखेंगे इस लेवल पे कि वाइटल्स पेशेंट के कैसे हैं, हम इसको ट्रांसफ्यूज भी कर सकते हैं अगर
देखिए वाइटल्स तो वंस वो सामने लिखा है 170 है एचपी ड्रॉप हो गया है
आफ्टर 52 आवर ऑफ ऑब्जर्वेशन है
हाँ 52 आवर्स ऑब्जर्वेशन बट समथिंग हैज चेंज्ड patient is complaining of flank pain patient is now developed gross hematuria HB is now 7 grams what is happening कुछ तो bleed कर रहा है ना
ब्रूच लेवल हो रहा है, एब्डोमिनल टेंडरनेस आ गई है तो फिर हम
ठीक है so one is that you go for CT cap the patient is vitally stable he's dropping HB you need to move fast so now there is an option of re-imaging ठीक है re-imaging के rules हैं but since we are short of time so इसमें we go for re-imaging and then we go for in this the grade has the patient is now becoming unstable so exploration is the part of the scenario तो जल्दी से आगे निकालते हैं
ये बीपी के अलावा कभी पल्स लेते हैं
सर वो सर वाइटल सर वो
मॉनिटर लगा हुआ लेकिन पल्स का कोई दिक्कत नहीं किया पल्स अगर रैपिड हो रही है वो ब्लड लॉस हो रहा है दैट्स द इंपॉर्टेंस
सर माय मिस्टेक सर मैंने पल्स
यहाँ कहीं पे भी पल्स का कोई दिक्कत बीपी का दिक्कत
ये सर आपने वैलिड पॉइंट है सर ये मैं वाइटल्स पे सब कवर कर रहा था बट इस पे हमने पल्स माय मिस्टेक सर ठीक है अच्छा आगे नेक्स्ट So there are two operative managements quickly. One is non-operative. There is a whole scenario in which जो non-operative इसमें deal करते हैं. Operative के अंदर options बस quickly. One in operative you have angioembolization. Second you have exploration. Exploration में rhinography and if very severe nephrectomy and then there is a concept of damage control surgery. ठीक है. These are certain indications in which you go for operative management. ये एक दफा पढ़ लें फिर हम खत्म करते हैं
So for operative management
absolute
indications are grade 5 renal injury with hemodynamic instability and there is no transient response to resuscitation. Then there is expanding our pulsatile renal hematoma. There is suspected renal vascular pedicel avulsion. There is PUJ avulsion. Relative indications are urinary extravasation with significant renal parenchymal devascularization, renal injury together with concomitant injuries such as colon and pancreatic injury, arterial thrombosis, and the urinary extravasation from parenchymal injury.
So we've now at least what we've learned today is the evaluation of renal trauma and your red flag to move towards your seniors if the patient is deteriorating and what to do. So since we're out of time, thank you very much. And inshallah, someday we will discuss the management of renal trauma that requires another level of discussion.
Thank you.